for Egmore, working as driver. He is a Hindu religion, belongs to Hindu religion, and lower middle socioeconomic class. Martial status is unmarried. Chief complaints: non-healing ulcer in the penis for the past 1 year, bilateral groin swelling for the past 3 months.
Good.
History of presenting illness: patient was apparently normal 1 year ago, after which he developed ulcer in the glans penis, which was insidious in onset, initially small in size, gradually progressed to attain the present size, associated with serous discharge for the past 3 weeks, which is not foul smelling, not associated with pain or itching, not associated with bleeding.
Okay.
History of bilateral swelling for
What's his age?
60 years old, sir.
Okay. So it's a non-healing ulcer. Go
Yes, sir.
back to the previous slide. So any ulcer in the penis, the first presenting scenario should be like this. Invariably, you expect some pain in a ulcer, normal tendency. But in a penile ulcer, what is the relationship of pain with the ulcer?
Sir, the ulcer due to infection due to cankeroid, it will be painful. Otherwise, it's mostly painless ulcer, sir.
Exactly. So all of you should remember that the one of the main or even the condition where a painful ulcer is present in the penis is chancroid. Okay, all other things, including a chancre, which is caused by Trypanosoma pallidum or the primary chancre, even that is painless. Okay, a CA penis ulcerated growth is painless. Uh, penile wart caused by papillomavirus is painless. Most often it is painless. The only recognized condition which is extremely painful and ulcerated is chancroid caused by what
Treponema,
organism?
treponema pallidum,
Chancroid. Chancroid.
chancroid.
Chancroid.
Hemophilus.
Chancre is
Hemophilus. Hemophilus.
Hemophilus
Bruce. Bruce Ray.
decree.
Ducre.
Decree. Okay. So chancroid is not Trypanosoma pallidum. Chancre. Okay, primary syphilis is caused by Trypanosoma pallidum. Chancroid is caused by Haemophilus decree. Right? Okay, so first, so essentially a carcinomatous lesion in a penis is painless. That's what you should remember. Okay, right.
Okay, sir.
One. Next slide.
History of
Yes.
bilateral inguinal swelling for the past 3 months, which was insidious in onset, progressive in nature, not associated with pain or discharge. No,
Okay.
his,
Okay.
no history of loss of appetite, no history of loss of weight, no history of
Okay.
difficulty in passing urine, no history of phimosis, no history of balanopostatitis, no history of fever, no history of trauma, no history of
Yes.
jaundice, abdominal distension, no history of bone pain.
Okay. Right. So when you elicit a history, one thing you should remember when you consider a case of CAP is what is the type of cancer which is common in say, penile cancer?
So squamous cell carcinoma.
Yes, it is squamous cell carcinoma. Okay,
Yes,
the
sir.
cancers in the digestive tract are usually adenocarcinoma, like
Yes, sir.
stomach, okay,
Yes, sir.
intestines, or pancreas. All those things are adenocarcinomas arising from gland, whereas squamous cell carcinoma is arising from the skin epithelial
Skin
tissue.
epithelium tissue. Yes, sir.
Okay, so the major difference between an adenocarcinoma and a squamous cell carcinoma is cell carcinoma is mostly loco-regional. Even if it spreads, it will spread vigorously locally only. It will fungate, become a big mass. And at the most go to the regional. Regional means lymph nodes.
Lymph
Okay.
node. Yes, sir.
Squamous cell carcinoma is very rarely a systemic disease. Kindly remember. Whereas a CA breast, even to start with, it is a systemic disease. The moment you notice it, it is already in the system by means of
Lymphatic.
microemboli. Tumor cells will be circulating in the blood and going off to distant places. It is a systemic disease. Okay?
Okay, sir.
Breast cancer is a systemic disease. CA stomach is a systemic disease. Pancreatic CA is a systemic disease. Only the manifestation will be very late, but it is already in the system by microemboli. Tumor microemboli will be there, but it's not the case with CAPs. See, all squamous cell carcinomas, for that matter, whether it be a penile cancer or oral cancer also. Okay, they are predominantly loco-regional. Okay, why I am telling that is when you are giving present history, uh, your main concentration should be on loco-regional complaints. Okay,
Okay,
so
sir.
immediately an examiner may ask, do you think that lung secondaries are common in penis? They may ask. Okay, bone secondaries. Do you think that bone secondaries are common in penile cancer?
No,
What
sir.
should we answer then?
No.
It is not common, sir,
Not common.
because
It is
penile cancer
loco.
is it is by and large loco-regional. Okay,
Yes,
will
sir.
fungate in the organ at the most spread to the
Hello. It's spread into the lymph nodes, regional lymph nodes. Hello.
with bleeding, erosion of vessel. Local regional roots will enlarge to that extent to erode the vessel, but even then it will not spread systemically. You understand?
Yes,
That's
sir.
it. So you have to understand the tumor biology. Okay, squamous cell carcinoma is by and large loco-regional disease, whereas adenocarcinomas of various organs are essentially systemic diseases. Okay, you will carry this point, don't forget it.
Yes, sir.
Okay, next slide. So your presentation complaints should be mostly the important things should be directed towards your regional and local aspects. For example, you were told there is no difficulty in passing urine. I agree totally with that because the tumor, when it invades from the skin, it may go to corpora. Okay, corpora cavernosa and corpora spongium also sometimes. And invasion of this beyond this may go on to invade the urethra, but it's very late. So difficulty in passing urine is a relevant complaint. Okay. Of
Okay, sir.
course, jaundice, abdominal distension, bone pain can be mentioned, but they should be mentioned at the last as you have done. You should understand the importance of this. That's what. Next one.
Past history. No history of similar complaints in the past. No history of circumcision. No history of diabetes mellitus, hypertension, tuberculosis, asthma, epilepsy, jaundice, sexually transmitted disease, or cardiovascular disease. No history of previous hospitalization.
Okay. What do you want to ask about circumcision history?
So circumcision history due to carcinoma penis is very rare if the penis is circumcised, as it is done in many religion.
Hmm.
Um,
Any
if it
timing
is
of circumcision?
Yes, if it is done in the early neonatal stage, there is actually 0% chance of carcinoma penis. But if it is done after 1 year of age, there will be a chances of circumcision. Uh,
Yes.
sorry, so, carcinoma penis.
Okay.
Uh,
What is the reason?
Due to there will be smegma production. So due to the
Okay.
irritation of the um,
So some amount of exposure to smegma itself might produce CA penis. That is a pathological understanding what we have. Okay.
yes, sir. Yes,
So
sir.
circumcision early soon after birth. Okay.
Yes, sir.
before infant period will give protection from CA penis, but circumcision and done at a later date is not bound to give 100% protection, because by the time delay you uh, give off before taking up circumcision, exposure to smegma is already there. That is our understanding of the pathophysiology behind that. Okay, so
Yes,
kindly
sir.
remember, circumcision done soon after birth, very early in the childhood, before the infantile period, he is found to give protection from CA penis, but not circumcision at a later date. Okay, right.
Yes, sir.
Next slide.
Personal history: consumes non-vegetarian diet, normal bowel and bladder habits, known smoker for 20 years,
Yeah.
one pack per day, that is 20 pack years, not alcoholic, history of sexual contact with multiple sex partners and unsafe sex present, history of poor genital hygiene, no history of drug abuse.
Okay. What will be the organ which is responsible for spread through sexual contact? Give me one organ. Microorganism.
Microorganisms, so, syphilis,
No. Give me one microorganism which is etiological in producing cancer.
human papilloma virus.
Yes. So sexual contact may spread uh, human papilloma virus 16 and 18, which might be a etiological cause. Right. Next.
Family history, no relevant family history. Allergy history, no history of allergy to any drug or food.
Yes.
Summary: the patient, Mr. Shekhar, 60 years old male, who is a chronic smoker and also has a history of sexual contact with multiple sex partners, presented with non healing ulcer over the glans penis for the past 1 year, which is associated with serious discharge for the past 3 weeks. There is also history of bilateral inguinal swelling for the past 3 months. I would like to examine the patient for a possible malignancy in the urogenital system, that is penis.
Good. Only thing is, you can just put one painless word here. Okay. Non-healing
Okay, sir.
ulcer, painless ulcer. Non-healing, painless ulcer over the glands. Otherwise, it is perfect. Very good.
Oh, okay, sir.
Next slide. Yes. This is how
General
you
exam.
should summarize after history. Okay, va? So she is slightly choosing the system which she is going to examine. That is the purpose of summarization. And you can briefly give whether you are contemplating whether it is a benign condition or a malignant. That would suffice at this stage. Okay, proceed, ma.
General examination. The patient is conscious, oriented to time, place, and person, moderately built and moderately nourished. No pallor, no icterus, no cyanosis, no clubbing, no pedal edema. Bilateral inguinal lymphadenopathy present.
Yes.
Vitals: pulse rate 80 per minute, respiratory rate 16 per minute, blood pressure 120 by 80 mm of Hg, temperature febrile.
Yes.
Local examination. After getting consent and explaining the procedure to the patient, patient was exposed from mid chest to mid thigh and was examined in bright light.
Yeah.
Inspection. Penis appears to be in the midline. Irregularly shaped ulcer on the penis involved whole of the glans penis and extending till the middle of the shaft. Which was ulceroproliferative in nature, of
Yeah.
size 5 cross 4 centimeter approximately. The margins were irregular and rolled out. Edges, everted edges. The floor was slough. Extent 4 centimeter distal to the root of penis involving the shaft and glans. Uh, Serous discharge, which is not foul smelling, is present over the ulcer.
Okay. It is occupying both the dorsal and ventral aspects of the penis.
Yes, no, not ventral, sir. Dorsal aspect, glans penis, sir.
Yes.
Whole of the.
So that if it is there, you can mention it. Otherwise, it is all right. Okay. Irregular shaped ulcer present over the dorsal aspect of the penis involving the whole of glans penis. So dorsal or ventral is very important. What is the significance of a purely dorsal ulcer, ulcerated growth, and one on the ventral aspect? Symptom wise, will there be any difference
So,
regarding spread?
yes, so it can be spread into scrotum or
No.
surrounding.
It has to go all the way to the root of the penis, then only you go to the scrotum, which is the other thing which may be involved earlier in a ventral placed
Urethra.
CAP. Yeah,
Urethra. Urethra.
urethra, exactly. So, an ulceroproliferative lesion, yes, penile cancer, which is more ventrally located, is likely to erode into
Involved
the
in.
ureter more earlier because you've got two corpora
And
cavernous are there on the dorsal aspect and
and
one
one
spongious on
corpora
the ventral
sponges.
aspect. Okay. So dorsal ஒரு lesion இருந்ததுன்னா it has to involve the Buck's fascia, it has to involve the albuginea, then come to the corpora, then only it can come and involve the
Urethra.
urethra. Whereas the ventrally placed ulcer is more likely to involve the ureter earlier than compared to a dorsally placed ulcer. You should understand. So, by putting this question, the examiner may as well judge your anatomical understanding of the penis also. Okay, right.
Okay, sir.
So, ventral lesions, earlier urethral involvement may be there, resulting in difficulty in micturition. Dorsally placed penile cancer, this problem will not be there usually. Okay, ma? Right.
Okay, okay, sir.
There. So, what are the significances of each of your finding? Let us go back and just revise it. So, it is also proliferative. Okay.
Uh, Margin is irregular and rolled out, which
Um,
is suggestive of null healing ulcer, and it is
yes.
has a rolled out margin, which is like a cauliflower
Yes.
proliferation. So it is basically the squamous cell carcinoma, and
Yes.
the edges are everted.
Okay.
Uh,
So, all findings are typical of a malignant ulcer. The shape
Malignant
is
ulcer.
irregular. Okay.
Yes, sir.
And the edges are everted. Okay. It is not foul smelling. At the same time, some slough is present. If it is
Yes, sir.
a non-specific infected ulcer, you will have the early onset of foul-smelling discharge, which is not the case here. So all your findings are almost suggestive of a malignant ulcer. Okay, next slide.
External urethral meatus, glands, and prepuce is not visible distinctly.
Okay,
Surrounding skin is edematous.
yes,
Bilateral inguinal lymph node enlargement of size 2 cross 2 centimeter on the left side and 3 cross 3 centimeter on the right side is seen. Overlying skin is normal. Scrotum
okay,
appears to be normal. No pigmentation, scar, signs is seen.
very good. Okay. So you cannot make out separately the prepuce and the glands as
Glands.
individual structures. They are
Yes, sir.
all uh, mangled and involved by the tumor mass. Am I right?
Yes, sir.
Okay, next slide.
Palpation, not warmth, not tender. Inspectory findings of site, shape, size, and extent of ulcer are confirmed on palpation.
Hmm.
Induration of the ulcer is present. Induration extends 1 centimeter beyond the margin of the ulcer. The ulcer does not bleed on touch. Glans, prepuce, and external urethral meatus is not seen.
What was the method by usually we make out induration?
Induration, the
Which part
thigh,
of the ulcer do you look for induration? What are the parts of ulcer?
floor, margin, base,
Edge,
uh,
floor,
edge,
margin,
floor, base.
base. Where do you look for induration?
Base,
Yes.
ul-
So when you mention the base is not indurated or induration is made out in the base of the ulcer. So to make an induration, you should not palpate on the ulcer. right?
Yes,
Either an
sir.
ulcer or an ulcerated growth is there. You should go away from it and put your finger. Suppose this is the ulcer like this. You should put your finger and press like this on the base. What is the base of the ulcer? It is the structure on which a ulcer is sitting.
Yes, sir.
Okay, the substance on which an ulcer is sitting is called base. Okay, so you should go beyond the ulcer and press and see like that. If it is yielding, then it means that the base is not indurated. If it is totally not yielding, like you are pressing a coin, just imagine an ulcer is there, below that one coin. Is coin pressable? It is not, no. So that will be the feeling in indurated base. It is suggestive of malignant ulcer from which there is overgrowth of tissue going into the base. Yes, there is extreme proliferation, making it tighten and it becomes indurated. Okay, so when you mention induration, you should mention induration of base. Okay,
Okay, sir.
and induration may extend beyond that margin as you told also, but the induration, the part of the ulcer where you should look out for induration is the base, right, ma?
Yes,
Okay,
sir. Yes, sir.
right. Yes.
Scrotal wall is normal, testis is normal, and testicular sensations are present.
Yes.
Spermatic cords are palpable and not tender.
Okay. Right.
Uh, Palpation of lymph nodes. Multiple bilateral hard mobile lymph nodes present in the inguinal region, not tender. Right inguinal region, largest node of size 3 cross 3 centimeter, firm in consistency, mobile and with well defined margin. Left inguinal region, largest node of size 2 cross 2 centimeter, firm in consistency, mobile and with well defined margins.
But you
Thin
are
over the
contradicting your own statement. What is the first line like?
multiple bilateral hard mobile lymph node.
Hard mobile.
Yes,
But here
sir.
you are telling firm. Stick to one.
Uh,
Okay.
okay, sir. So,
Do you mean to convey anything by this? Tell me.
no, sir. So there were multiple nodes. So the largest node is firm in consistency, mobile, and well-defined margins, sir.
Others are hard.
Yes, sir.
You stick on to one. Anything is all right.
Okay,
But,
okay, sir.
but usually, uh, if a disease process is involving a group of lymph nodes, okay, which is non-inflammatory, both will be mostly of all will be of same chronological duration, same duration. So I think the consistency will be mostly even in all things, except in inflammatory group of lymph node enlargement, like tuberculous lymphadenitis. Some nodes may be firm, some may be caseate and become fluctuant or cystic. Right?
Okay, sir. Okay, sir.
Tuberculous lymphadenitis typically has got variable consistency in different nodes. So caseation occurs. Caseation இருக்கிறதுல கொஞ்சம் சிஸ்டிக்காக இருக்கும், மற்றது ஃபார்மாக இருக்கும். This is never a feature of tuberculous lymphadenitis. Whereas in a malignancy, it is the deposit of malignant cells arising from
Cells.
the tumor. So they keep on depositing. So that chronology, for example, 3 months, equal amount of cells will be coming and getting deposited. So initially it might be firm in consistency. All of them will have similar consistency. For a period after another 2 or 3 months, excessive cells become deposited and all will attain hard in consistency. So you stick on to one. Okay? Right.
Okay, sir. Okay, sir.
Right.
Other system examination.
What group of lymph nodes are involved?
So inguinal lymph.
What are the two groups of lymph nodes in the inguinal region?
Ilio inguinal.
No, it's inguinal only. You got a horizontal group.
Superficial.
Right.
Okay, sir.
Horizontal group usually comes from which region and vertical comes from which region? It's like looking like a correct exam class, right?
No,
They will
sir,
ask you
I was
similar questions only.
confused,
Uh,
confused with superficial and deep, sir.
Horizontal
Horizontal.
lymph node drainage is mostly from lower abdomen, okay,
Okay, okay,
groin,
sir.
below the umbilicus. Whatever thing is drained will be drained by the horizontal group of lymph nodes belonging to the inguinal region. Vertical groups of lymph nodes usually drain the lower limb. Okay.
Okay, sir.
Lower limbல வர்றது vertical groups யூஸ்வலாக வரும். Horizontal groups usually by the lower part of the abdomen, infra-umbilical region will be draining into the horizontal group. You are aware of that? There are two groups. You should have read in your anatomy. In inguinal region, there is one horizontal group and a vertical group. Okay.
Yes, sir.
So if you are examining a case of squamous cell carcinoma arising from the foot, then that dissemination will come and involve the vertical groups first.
Vertical group.
So usually the genitalia will usually be in the horizontal group mostly. Yes.
Okay, sir.
So, next slide.
Other system examination, abdomen soft, no.
I'll just address the others also. Students, rest of you, if you have any doubt or any contradictions in my teaching, you can always come out. Okay? Yes, you can unmute and talk with me or post it in the chat. If you have any doubts, you can get it cleared then and there. No problem. Okay. Other systems?
Abdomen soft, no organomegaly, no palpable mass. RS, normal vesicular breath sound. CVS, S1, S2 heard, no murmurs. CNS, no focal neurological deficits.
Yes. Among all this, which one you would like to be most commonly involved? Many systems are there.
Sir, if pelvic nodes, if the metastasis has reached the pelvic nodes, the lower abdominal system.
Exactly. CVS is seldom involved. In any system, it is very rarely involved. Okay?
Yes,
Only
sir.
in thyroid, there are some serious findings which may be secondary to your surgical problem. Respiratory system, like systemic diseases, you will have secondaries like testicular cancer, okay, or
Okay, sir.
breast cancer, sometimes gastric carcinoma, all those things. Respiratory system is commonly involved in some systemic cancers. But CVS is almost not involved by any of our tumors. CNS may sometimes be involved. But in squamous cell carcinoma, especially from genitalia, only the abdomen need to be concentrated because the iliac groups and para-aortic may be sometimes involved. Okay, right.
Yes, sir. Diagnosis, a case of carcinoma penis with bilateral palpable inguinal nodes, stage T2, N2, M0.
Okay. So why you say N2?
So, because more than one inguinal lymph node is palpable, sir. So, it is has spread into more than one inguinal lymph node.
Okay, right. Why do you want to give a diagnosis of CA penis here? Just,
To for appropriate treatment, sir.
no. You already said it in your clinical examination, but I want you to give the important cardinal features which made you to diagnose that this one is cancer penis, not any other lesion other than cancer. What are the cardinal features from your history and clinical examination which makes you think that this is a CA penis?
So, first of all, the age. It is elderly aged patient.
Good.
Then he has a history of chronic smoking, so it increases the incidence of carcinoma penis.
Okay.
And the most important history of multiple sexual partners
Yes.
with the unprotected sex, and
Yes.
then the ulcer was proliferative in nature and rolled out edges,
Good.
everted.
Yes.
So it is clearly telling that it is a carcinoma of
Base is
penis.
indurated.
Base is indurated. Yes, sir.
Everted edges, indurated base. These are all two cardinal features of your examination. Okay?
Okay, sir.
And
Yes, sir.
associated lymph node, which is firm to hard in consistency, sometimes gives suggestive of cancer. Okay, right. What will you do for the patient?
Investigation. First, we routine investigation. Complete blood count, hemoglobin, bleeding, clotting time, bleeding time, ESR, blood sugar, creatinine, urine sugar, urea, albumin, and culture sensitivity to check if there is any infection or inflammation. Chest X-ray, ECG, COVID RT-PCR. In serology test, HIV, HPSAG, VDRL,
Yes.
and renal functional test.
Okay. Specific investigations.
Specific investigation, wedge biopsy of the ulcer, then punch biopsy of proliferative growth, FNAC of inguinal lymph node, sentinel lymph node
Want to do wedge
biopsy.
biopsy or punch biopsy?
Sir, actually, wedge biopsy is um, more.
You prefer wedge biopsy for this case, right?
Yes, because
Okay.
in punch biopsy there will be only 2 millimeter of specimen, so we can't see that much.
What is the indication for punch biopsy? You've seen a punch biopsy
Proliferative.
process? Huh?
No, no, sir.
Yes. So, in a lesion, pathological lesion which is well exposed and accessible, okay? Here
Okay,
is an
sir.
organ which is well accessible. There is no difficulty in reaching it out. In those cases, wedge biopsy is the preferred choice. Okay,
Okay,
punch
sir.
biopsy is indicated only in lesions which are situated in inaccessible areas, right?
Okay.
Like
Yes.
vaginal fornix. இல்லையா?
Yes, sir.
It is not accessible. A speculum, you will not be going and easily able to take it. It will be deep in the fornix. So what you put your hand and put on punch forceps, and without actually seeing that, you can feel and crush it and take. That is called punch biopsy. So indication for punch biopsy is for the lesion situated in an inaccessible depth area, like a lesion situated in the fornix
Vaginal.
of the vagina or a high rectal lesion. See a rectum. உள்ள இருக்கு அதை நம்ம என்ன ஸ்பெக்குலம் ப்ராக்டோஸ்கோப் போட்டாலும் கிட்ட போய் நம்ம எடுக்க முடியாது, கஷ்டம். ஓகே, அண்ட் posteriorly placed oral cancer, posterior 1/3 of tongue அல்லது டான்சிலர் fossa ஒரு பெரிய லீஷன் இருந்ததுன்னா it is very difficult to accessibility is very limited. You cannot go and take a wedge biopsy including normal surrounding skin. It is not very easy. So you understand?
Yes, sir. Yes,
For
sir.
this, it is enough if you tell a wedge biopsy. Punch biopsy is reserved for those areas which are difficult to reach or inaccessible or situated in depth. Okay, there only you take punch biopsy. You have seen a punch biopsy forceps?
No, sir.
For a wedge biopsy, there is no forceps. Okay, you just infiltrate some local anesthesia, take a 11 blade, cut like a pizza end, or triangle மாதிரி நார்மல் ஸ்கின் கொஞ்சம் அது நல்லா டெப்த்தில் எடுத்து வச்சிடலாம். ஒரு கேக் கட் பண்ணுறோம்ல ஒரு கார்னர், அது அவ்வளோதான் அது wedge biopsy. Okay, you need no special instruments. But for punch biopsy, there is a biopsy forceps there. In front of the forceps, there will be one crushing end on one perforated end. So it will go, and the tissue will be in the middle, and it will crush and take a chunk of tissue. So you have a specialized forceps for punch biopsy, right, ma?
Okay, sir.
Don't forget what are the conditions where punch biopsy is used. You should know. Okay.
Okay,
For
sir.
this lesion, wedge biopsy is good enough. Okay. Then,
FNAC of inguinal lymph nodes,
very good.
then sentinel lymph node biopsy.
Why? For this
Because
case,
It is the first lymph node which
This is the
uh,
biggest mistake you are making in your presentation.
uh,
Sentinel lymph node biopsy, where it is done in any system.
If surrounding draining lymph nodes are not palpable.
It is done in a clinically negative
okay, sir.
only. Okay.
Okay, sir.
Palpate பண்ண முடிஞ்சா அது பண்றது sentinel node biopsy கிடையாது. Okay. So
Okay, sir.
whether sentinel node biopsy in a CA penis or an axilla breast cancer, it is done only in a clinically negative axilla or clinically negative groin only.
Okay, sir.
அப்பதான் நம்ம சென்டினல் நோடு எந்த நோடுன்னு பார்த்து நம்ம எடுக்கணும். ஓகேவா?
Okay, sir.
Clinically positive nodes இருந்ததுன்னா it means that the disease has spread. We can use FNAC and come out. That's all. Right? So
Okay, sir.
never ever mention sentinel node biopsy when clinically regional lymph nodes are positive. It is the biggest mistake. You should avoid. Erase that out. Okay?
Okay, sir. Okay, sir.
Only clinically negative status, only you do a sentinel node biopsy. Remember that, yes.
Okay, sir.
So here, of all the investigations, wedge biopsy will be the first and foremost decisive investigation. Then FNAC of lymph nodes, okay. That FNAC you can tell, if it is not very conspicuous, you can even use a image-guided FNAC of the groin. It is accepted. But well made out nodes, you can straight away take it. If it is vaguely felt, you can do a image-guided biopsy where you can take the biopsy from representative area, namely very solid area. If the nodes are mixed consistency, cystic solid consistency is present, you can target the solid area and take which will be more informative. That is accepted. All right.
Okay, sir.
Okay, right. So wedge biopsy, FNAC only will take. Punch biopsy, not accepted. Sentinel lymph node, not at all accepted. Okay, va?
Okay, sir. Okay.
Right. Okay. Next one.
CT abdomen and pelvis for iliac.
Yes.
If there is inflammation of iliac lymph nodes.
Accepted.
Then PET CT for distant metastasis.
This is not accepted.
Okay,
This
sir.
is a
Because
superfluous.
you said
Enama?
because you said local, it is CA penis
Yes.
is loco-regional.
Yes. And that too, for a primary penile malignancy, it is not indicated. Sometimes what happens, you primarily treat a patient with a partial amputation of penis or total amputation with a perineal ureterostomy, and the patient comes back for follow-up after 6 months, 1 year. Again, he is having some problem. Then for recurrent disease, PET CT has some role, we will accept it. But this is a primary disease, PET CT is not accepted. It is a superfluous infection, investigation, which is not accepted. So, Janani will
Yes, sir.
retain only
Wedge biopsy, FNAC,
Yes.
and
Yes.
CT abdomen and pelvis.
Very good. And even ultrasound abdomen also is some amount of imaging of the abdomen is all right. You mentioned CT, will accept it. So you will not forget this in your future, right?
Yes, sir. Yes, sir.
The rationale of choosing the investigations you should always understand. Okay?
Yes,
Very
sir.
well done. But happy you have come out with all these things. But I think you will also realize how rationally you should do the investigations for that particular case in your hand. Okay? Very good.
Yes,
Next
sir.
one.
Yes, sir.
Okay.
Treatment primary lesion, that is ulcer, total amputation of penis with perineal urethrostomy. Then for lymph node, we will give for antibiotics for first 3 to 6 weeks for exclude infective etiology. If it is not coming down, then we will do a bilateral ilioinguinal block dissection.
Now I want you to reason out two things here. Go back to your inspection finding.
Inspection and finding.
Your examination. What is the location of the ulcer?
So glans penis and extending to till the middle of the shaft.
Okay. What is the distance from the root of the penis?
4 centimeter.
Okay. You want to do a total amputation for this patient?
So, sir, since it has spread till the shaft and the nodes also infected, so that's why
Okay. So
we can't get
dismembering an
the.
organ is a great loss for the patient, and it's
Yes,
a
sir. Yes, sir.
great loss which cannot be replaced. You should always think time and again before dismembering an organ. You cannot put it back. Okay.
Yes, sir.
So
Yes.
this is the biggest principle in deciding whether you want to organ preservation with the amputation or dismember, lose the organ. The criteria, can you come out with some criteria, Any other student can answer? I'll first ask Janani. How do you
So,
choose between partial amputation and total amputation?
so for partial amputation, if the growth doesn't involve the proximal part of shaft,
Okay.
then we can proceed with partial amputation.
Is that is
And
that the whole criteria?
uh,
Two
The
things you should
stump,
remember.
the
As
stump
stump.
and
size of 2 centimeter.
as and when possible, penis should not be removed. A partial amputation is to be preferred over a total amputation if it is possible. Number one principle.
Okay,
This
sir.
to be understood. Second
Okay.
principle, anybody can tell?
So stump size 2 cent. If
Ah,
we get if greater than 2 centimeter, we can leave. Can do partial.
very good. So, available viable stem, we call it. Okay. After your intervention, if you can offer the patient 2 centimeter of viable penis, you should always do a partial
Partial
amputation. Okay,
amputation.
wow.
Yes.
So you have a penile shaft, you have a lesion. Generally, we give 2 centimeters diameter clearance, and after giving that clearance, you should have 2 centimeters of viable penile stump. Understand?
Yes, sir.
So in this case, you have obviously told the ulcer is situated at 4 centimeters from the root of penis. So there is another 2 centimeter plus 2 centimeter clearance. So you can give 2 centimeter clearance and amputate the penis. Still, you will have 2 centimeters of functional stump,
Function.
viable stump. Understand?
Okay,
So,
sir.
other students also, I want you to clearly understand the criteria for choosing between partial amputation and total amputation. For a partial amputation, after giving sufficient margin and resecting, if you can give the patient a viable stump of 2 centimeters from the root of penis, you always going for partial amputation. Okay? Right. So what will you do now, Janani? Come back to the our slide here.
Uh, yes, sir. So
You would like
partial
to
amp.
you
Yes,
would
sir.
like to revise
Partial.
yours? Yes.
Yes, sir. Yes, sir.
It is partial amputation of penis only.
Penis.
Okay.
Okay.
Right.
Okay.
Then lymph nodes.
Lymph nodes, sir. By bilateral ilioinguinal lymph node
No,
block dissection.
straight away you want to go
No, no,
for
sir. Now, first we will see if it is regressing if we give the antibiotics,
but
which is,
I
or
think you mentioned about FNSA of the lymph node. Does it help you in any way?
it will tell it is infect. Uh,
3 to 6 weeks. So the concept here is this process of giving antibiotics for 3 to 6 weeks and then carrying out was done in pre-FNAC era. அதை நம்ம இன்னும் பிளைண்டா அதே ஃபாலோ பண்ணிட்டு இருக்கோம். புரியுதா?
okay,
For
sir.
example, the period when we were doing our graduation, fine needle aspiration cytology எல்லாம் கிடையாது. There is no way of knowing whether it is containing uh, uh, malignant deposits or not. Okay.
Okay,
So they
sir.
presumptively treated the patient for the 6 weeks and waited. If it regresses, then it is well and good. It is infective. Otherwise, it is that is pre-FNAC era. Now,
Okay.
FNAC available. You can make it out within hours. So I think the concept of giving antibiotics is blindly being followed, which is not reasonable. ஓகேவா?
Okay,
நீ
sir. Okay.
வெயிட் பாக்ஸ் பண்ணிட்ட, சிடி ஸ்கேன் அப்டமன் பண்ணிட்டீங்க, then you have done a what other investigation you have done?
FNAC.
FNAC of the nodes you have done. So FNAC ல வந்து malignant deposits வந்துன்னா right away it is a positive groin. You have to go ahead and do a block dissection of the inguinal region, and because this is palpable, the next higher level also should be removed. Okay, right.
Okay, sir.
So if I am the examiner, I will think rationally like this only. FNS is positive, then you have to go ahead with your block dissection. Nothing stops you, or you should do it. Okay.
Okay,
If
sir.
it's negative, then perhaps you can treat it with antibiotics with the presumption that the enlargement is not due to malignant deposits. It has got no role in deciding upon the block dissection. Okay. So
Okay, sir.
the complete treatment to be planned for this patient is partial amputation of the finish, followed by, based on FNAC of the inguinal region, we'll decide on whether we'll do a bilateral ilioinguinal block dissection. That's all. Okay.
Okay. Okay, sir.
Right. Right. So the criteria for partial amputation I have told you. How will you go on to do partial amputation?
So partial amputation, we retain the 2 centimeter from the root of penis,
Hmm. I
and
mean, what anesthesia you will give?
so general anesthesia or spinal can be given.
Hmm.
Mm,
So, okay. And supine position you will put, and you will put a tourniquet around the root of the penis in the form of a small tie. You will compress it so that it does not bleed very much when you cut. Then mark the clearance margin. அல்சரை
clearance.
பார்த்து அதுலேருந்து 2 சென்டிமீட்டர் வச்சு ஒரு பெண்ணால மார்க் பண்ணிக்கணும். Then you also make sure that there is excess of 2 centimeter proximal to that shaft is enough. Also, you should decide and confirm. Okay.
Okay,
Then
sir.
proceed with the total amputation. The procedures we can read from the operative surgery book. Okay.
Okay, sir.
Only thing is the corpora cavernosa will be bleeding heavily. Skin by bucks fascia, you incise, you will have the dorsal vein of penis, you should tie. Small arteries will be there. But when you go through the corpora cavernosa, cavernosa means what? It is like a cavernous means a cave-like thing, which is interwoven with blood vessels. So it will bleed heavily. So you'll have to take a circular 8-shaped stitch and compress it so that the bleeding does not occur. And in the corpora spongiosa, you will have the urethra. You should give a extra urethra when you cut it, and then splay the urethra. Urethra or 12 o'clock and 6 o'clock positions, you make a cut, or you can do it in 3 and 9, 180 centimeters, and then splay the urethra. வெளிப்புறமா ஸ்ப்ளே பண்ணி அதை ஸ்கின்னோட ஸ்டிச் பண்ணணும். யூ ஷுட் டேக் எ ஃப்ளாப். I think you can go through some operative surgery, Ferguson's or some text, and just go through it. Okay. What we want you to mention is what type of anesthesia you will do, what is the position of the patient you will do. Okay. Right. Then so for all other cases where 2 centimeters of non-viable, viable stump is not possible, you choose to do a total.
The total.
Yes, where
Total
viable stump
amputation.
you cannot offer, it is very proximally placed. You do a total penectomy with perineal Urethrostomy.
Urethrostomy.
Okay, what will you do with the testis then?
Mm, testis. If total.
There are two lines of thought. Some people choose to do bilateral archaectomy also.
Okay, sir.
The reason is when the penis itself is gone, the testis has got no use. Even if it is going to secrete testosterone, it is going to be of no use, and they will remove the scrotum also, because if you retain it, the patient will get ammonical dermatitis, they say. Okay. Perineal urethrostomy வச்சுட்டா அதுல இருந்து spurt of the urine won't be going. It will be wetting the hanging scrotum, which will develop ammonical dermatitis. So the proponents of archaectomy group, archaectomy கூட சேர்த்து பண்ணணுன்றவங்க சொல்ற ரீசன் வந்து, without a penile organ the testis is not useful, so we will remove it. If you retain the testis with the scrotal skin, the patient is liable to develop ammonical
Scrotal dermatitis.
Okay, wow.
Yes,
Some
sir.
people, those who prefer to retain the testis, say that though the organ is not there, psychologically the patient will be better if testis is retained. That group says. But I am personally in favor of removing the testis along with the scrotum. That is called emasculation. Emasculation. That is total penectomy with bilateral archaectomy with scrotectomy also. Okay, right. So having come to that, a few questions about CA penis will also be asked. So the type of cancer in CA penis is
Squamous cell carcinoma, adenocarcinoma.
Yes, commonest is squamous cell carcinoma.
Squamous cell
Tell me
carcinoma.
a few pre-malignant conditions which you can.
Phimosis.
Tell me the common things. Phimosis is only a contributory thing. It is not a.
Leukoplakia.
Leukoplakia, yes. There are more important precancerous lesions. Yes.
Erythroplakia.
Erythroplakia is very, very important. Okay.
Yes, sir.
Erythroplasia is very, very important. What are the two types of erythroplasia, you know? One is occurring in the glands, one is occurring in the shaft. The erythroplakia occurring in the glands penis is called erythroplasia of Curie or Curette. அதே ஷாஃப்ட்ல நடந்ததுன்னா Bowen's disease னு பேரு. Both are intraepithelial neoplasms of the penis. Okay, or they are called carcinoma in situ. இது எல்லாமே ஒரே டெர்மினாலஜி தான். It is carcinoma in situ or intraepithelial penile neoplasm. When it happens in glands, it is called erythroplasia of Curie. If it happens in shaft, it is called Bowen's disease. Okay, this whole thing is erythroplasia or carcinoma in situ. Any other lesion? Precancerous.
Chronic balanoposthitis.
Yes, that is called BXO. Balanitis xerotica obliterans. Okay, BXO is one of the conditions. Any other thing?
Condyloma accumulata.
Condyloma accumulata is very good. That is one of the most important pre-malignant lesions. Okay. Then your penile warts also caused by human papilloma virus are also contributory some of the pre-malignant lesions. Okay. And your phimosis and leukoplakia are less contributory. They should come last. First one is erythroplasia. Then next one is condyloma accumulata. Then the other BXO will also be there. Genital warts will be there. And last you can tell phimosis and your leukoplakia. Okay. So apart from your surgery as a modality for treatment of squamous cell carcinoma of the penis, is there any other modality of treatment for primary penile cancer?
Primary, sir, if Urethral and scrotum is involved. We can go for radiotherapy.
Hmm.
Bulbar, bulbar urethra and scrotum.
That is not curative. It is advanced disease you are telling. It is all right. Even for a early lesion, radiotherapy can still be useful. Okay. So, the dorsum of penis over the um, uh, corona region is example you take. There is a small 2 into 2 centimeters lesion which is not deeply situated. The patient is not willing for any surgery. We can try out radiotherapy also as a primary modality of treating the cancer. Okay. What are the types of radiotherapy you can give?
Uh,
External beam. External
Yes.
beam.
Very good. EBRT. There are three types of things
Brax.
possible. One is what Anup has correctly told. It is external beam radiotherapy, where the organ is kept and the external beam from a uh, uh, radiation ejector is received on the organ. That is called EBRT. What is the other type of thing which can be given?
Brack.
Brachytherapy.
Brachytherapy.
Brachytherapy. Yes, very good.
Brachytherapy.
Brachytherapy is given in the form of what? In a
Tantalum wires.
yes. So iridium wires or cesium wires or pellets are there. Okay. Importantly, in a CA penis, iridium wires can be implanted in the ulcer cancer area, and the radiation can be given to the cancer site. Any other method?
Radium mold
Yes.
applicator.
So radium emitting mold can be fixed to the organ, and over a period of time that will be rendered. So what you should answer is which can be chosen for primary treatment of penile cancer is radiotherapy. It is indicated for smaller proximally located lesions or condition surgery is not indicated for the patient. This can be an alternative. The radiotherapy treatment for penile cancer can be either by external beam radiotherapy or by brachytherapy. Brachytherapy means it can be also be of two types: implantation of iridium wires
Wires.
through a
Hearing
radiation mold,
radium. Okay. Yes.
radium containing mold which is applied to the penis. Okay. So, is there any other method to treat very superficial penile cancer?
Chemotherapy, sir. 5
Chemotherapy.
fluorouracil cream. 5
Yes.
fluorouracil
The
cream.
earliest lesion you can apply 5-fluorouracil cream. Okay. Or
Yes,
any
sir.
other surgical microsurgery is available.
Most surgery.
MMS. Okay. Small superficial lesions can be subjected to microscopic surgery. Most microscopic where small slices are taken of the cancer, and one small slice you take, put it in the microscope and see if it is carcinogenic. If it is positive, then take the next small shave from that place and again examine it. You take small, very thin slices and keep on examining it till it turns negative for malignancy. That is called most micrographic surgery, which is also there is a role for it in penile cancer. Okay, right.
Yes, sir.
What are the terminal events we expect of a cancer? Most of our patients are coming very late in the disease, not early, because of it's a stigma,
Yes, sir.
they
Yes, sir.
don't readily want to accept that the private parts are diseased. So they do come very late. What are the terminal events for a
So
neglected patient? Yes.
they can it would be fatal due to fungation and bleeding, a hemorrhage, uh,
The
hem-
patient can develop extreme sepsis and going for sepsis and die.
die,
Fungating mass, ഭയങ്കര foul smelling ആയിട്ട് sepsis ആയി they can die. Next one,
hemorrhage,
from there.
artery,
Femoral arteries.
femoral artery.
So the hemorrhage will not be from primary penile cancer. It will be from nodes. Nodes will grow
No.
vigorously and erode the underlying femoral artery or even external iliac artery, they say, if it goes up. Okay.
Yes,
So
sir.
terminal death may occur due to torrential hemorrhage due to erosion of major vessels by the lymph nodes. Okay, that's also a possibility. And the patient may, urethra is extremely involved. The patient may go in for obstructive uropathy, but it will be very late. The patient will go for uremia and other things, but it's very common. Even before that, the patient will meet his end due to what causes we have discussed here. Okay,
Okay,
right.
sir.
You got any doubts here? I think Janani, you have got a few take-home points which you will not forget.
Yes, sir. Yes, sir.
Criteria for choosing between partial
Partial
amputation
amputation
and
and total amputation,
total amputation.
and
The
rational investigations.
yes, we should not just like that mention everything. Punch biopsy எந்தெந்த இடத்துல பண்ணணும்ன்றதுக்கு I have mentioned a few
Yes,
things,
sir.
and
Yes,
also
sir.
the role of antibiotics in treating groin. What is the perception? If it is being blindly followed, you should reason it out. Okay?
Okay. Yes, sir.
Right.
Yes, sir.
Thank you. And others, Anup, Gokul, if you have any doubt to be clarified, Karthik, and all of this, you can just come out if you have any doubt. I'll wait for a few minutes, 2 minutes perhaps. You have any
Sir,
doubt, Janani? The
sir,
presentation is good, ma.
Sir,
I think you have
sir,
got
if this,
you become well versed in summarization. I like that. The content
thank you,
part
sir.
also you should make some understanding. Yes.
Yes,
Tell
sir.
me,
Yes,
what
sir.
you had some doubt. Tell me.
Sir, if this case presented with fungation like proliferative and purulent discharge and foul smelling,
Hmm.
then we should proceed with the same treatment, or we should like first give antibiotic and then see.
You should start on antibiotic, but not wait.
Okay,
So
sir.
it's not going to clear the antibiotic is not going to clear your infection once for all. It should be minimized so as to allow you to carry out surgery. So
Okay, sir.
you cannot wait for antibiotic to act fully and completely wipe out the infection. It is not possible. As soon
Okay,
as the
sir.
patient comes, you see it's foul smelling, you straight away start on antibiotics. By the time you prepare the patient with investigations and everything, the infection could have come some control. That is enough. Okay.
Okay,
There
sir.
is no time period to wait for full infection to subside. It is not possible. But reasonably, the infection could have been contained to make you do surgery at a safe manner. Okay. Right.
Okay, sir.
Right. Thank you. If that's all, what's tomorrow? Tomorrow you have got a class.
Yes, sir.
So malignant melanoma, sir. Tomorrow's topic.
Tomorrow we have got a conference on hernia.
Okay, sir.
Isabel Hospital is hosting it, and I am one of the faculties. I don't know whether I will be free by this time. Kindly contact me and make before convening the class. Right?
Yes, sir. Yes, sir.
Who's the Kartia is the admin?
Yes, sir. Yes, sir.
You just contact me, ma. I am not sure of the timing tomorrow. If I am done with that program, I will surely start the class. If it is so, what's the topic you told me?
Malignant melanoma, sir.
Okay, we'll do it. But kindly consult me before convening the class.
Yes,
Okay,
sir.
bye.
Sir, can I call you at around 3 o'clock, sir?
Yes, you call me. If I don't pick up, text me. Right.
Okay, sir.
Thank
Yes,
you.
sir. Thank you, sir.